Welcome, everybody, to today's episode of the Association of Pulmonary Advanced Practice Providers podcast. I am your honored host today, Tyler Kuhk. I'm a pulmonary nurse practitioner based out of Bellevue, Washington, also an outgoing board member and the outgoing COPD committee chair. And I'm really excited to be here. I'm sure a couple people watching have probably seen some of my talks at APAP conferences in the past on chronic cough. And I'm joined today by a colleague of mine, actually, a very dear colleague of mine, Rachel Englund, who's a speech language pathologist. And Rachel's been in practice for the past 15 years. 12 of which have actually been at my organization. And her and I met about 10 years ago when I started in practice. Um, and we have some mutual interests, of course, with chronic cough. And Rachel's area of interest is in the upper airway spectrum of disease. So what we want to talk about today, moving beyond chronic cough and kind of the standard things that we've talked about at our conference, and really move into a conversation on refractory chronic cough and really understanding the role of some of the tools that we have available to us, which right now are very limited, right? The future is looking promising with some new therapeutics on the horizon, but I really wanted to take some time to talk with Rachel about the importance of speech language pathology and what speech language pathologists can offer patients with refractory chronic cough. So, Rachel, thanks for joining us this evening. I'm looking forward to a great conversation.
Thank you for having me.
So, before we dive right into, the refractory chronic cough and speech language role, I wanted just to kind of review what we're kind of talking about. So, when we're talking about chronic cough, remember we're talking about that cough that's lasting more than 8 weeks. Okay. And some facts just to kind of recap that this is an issue that affects nearly 10% of the global population. It's associated with increased healthcare costs, increased healthcare utilization, and it's a female predominant problem. Typically, chronic cough has four main reasons. We're typically looking at airways disease or upper airway cough syndrome or GERD and laryngopharyngeal reflux. And so this is typically what we do when we're working this up. And if you're watching on our YouTube channel, I will put up the chest guidelines for the chronic cough algorithm, which looks a little bit daunting, but once you kind of utilize this in your practice, it becomes like second nature when you're working through workup for your patients. So, most of the time when we use this algorithm, with about 90% of patients, we do get some success because we can identify an underlying reason and treat it. But at the end of the day, despite using this algorithm and treating for these most common reasons, about 5 to 10% of patients don't respond. Right. And so that leads to a fairly large population of individuals with chronic cough with unmet needs. And we already know the significant quality of life impacts on chronic cough in general. This gets even more profound in the refractory chronic cough population. And that's what we call it when it gets to the point where we have kind of done our workup, it's not working, or we just really don't know why the patient has a chronic cough. So when we move along this algorithm and we've kind of done our due diligence in terms of the most common causes, there's actually another algorithm, and I'll put that on the screen right now, that we can use when we're dealing with patients that have refractory chronic cough. So if we've done some additional workup and ruled out other things, other rare issues, like we've done CTs, we've maybe sent them to GI, things like that. We get to the end of this algorithm and it tells us that we can consider several different things. So we can, first of all, recruit the patient to a clinical trial. We can refer the patient to a cough clinic, which in the case of my practice is me, and we can try an empiric trial of something like gabapentin. But then we can also have speech and language intervention. And I give talks on chronic cough quite a bit. And I think one of the things that most clinicians, when I'm talking about this issue, is what does speech therapy do? They don't quite understand it. And so I figured that this would be a great conversation to have, to kind of educate our viewers and our clinicians on just exactly what speech therapy does, and how they help our patients, because I can speak to the wonderful work you've done in your team, and I have plenty of patients that have benefited from it. So I kind of want to transition now that we've kind of had that review and talk about why would a clinician even refer a patient with refractory chronic cough to speech therapy?
Yeah, it's interesting because I will have doctors describe speech therapy, and they'll say things like, "I don't know exactly what you guys do. It's this mystical, magical, behind the curtain thing where a patient all of a sudden goes to you and then they come back and they're better. But I'm not totally sure what you're actually doing with them, but I know that it works." So, yeah, I'd love to kind of peel back the curtain a little, if you will, and let you see what happens behind in a typical speech therapy session. So, most of my patients are that 10% where they have tried all of the medical interventions. They have seen all of the medical specialists. They've been living with this cough. It is significantly impacting their quality of life on a regular daily basis. And they're coming to me as sometimes being told that I'm the last ditch effort. I've literally had providers say that or say something along the lines of, I don't know that it's gonna help, but we have nothing else to try. And patients always come to me, they're a little skeptical, they're a little unsure, and I think that can be kind of a good thing. I think healthy skepticism around why they're gonna spend time, financial resources to come visit a speech therapist of all things after they've been through the gamut of specialists. So within the realm of chronic cough, from my perspective as a speech language pathologist, it's gonna fall under that irritable larynx syndrome continuum, along with other conditions like laryngospasm, paradoxical vocal fold movement, other conditions. Some people kind of more generically will call things like vocal cord dysfunction, right? So it's that continuum of with a constellation of hyperkinetic laryngeal symptoms, oftentimes accompanied with laryngeal hypersensitivity. So, this is where speech therapists, especially for those who practice in voice therapy, this is where we know something and we know a bit about the behavioral components and how the vocal folds are being used. And so this is where a lot of SLPs will get pulled into the room is because it falls into that continuum from our scope of practice. Um, so when you've done the medical workup, you have done all of the interventions, it's been exhausted, that's when the referral comes through. And in a way, I think that's the right way to do it because it ensures that we've ruled out all of the big bads. When I first get a referral from a provider, the things that I'm going to be looking for is have they seen pulmonology? Have we ruled out any underlying potential issues? Have they had spirometry work done? I'm going to be looking at those spirometry graphs to look for flattened inspiratory loops or anything else to suggest some kind of an upper airway restriction. Have they seen an ENT? Have they had a laryngeal examination, something to look at their vocal folds that say, yep, everything looks healthy and happy. A lot of our patients with chronic cough may not have voice changes. So you may not think, oh, this is a voice issue if their voice is totally normal. Some do have some underlying muscle tension dysphonia or other voice changes, but a lot of them don't. So oftentimes it's not something that you're thinking about when you're talking about referring a chronic cough patient to our clinic. I'm also going to look for information like if there's asthma or allergy specialists as well as GI. One of the things that I'm always going to look for is whether, as you talk about some of the contributing factors or etiologies that can cause this chronic refractory cough, are there things that are being treated concurrently, or was it all in sequential fashion? Did they go see an allergy or an allergy specialist, and do treatment for postnasal drip? And then, oh, that didn't work after 6 weeks. Now let's try GI. Let's treat that for 8 weeks. Oh, proton pump inhibitor didn't work. So let's go off of it. Were things done in a concurrent fashion? So that's one thing for me when I think about the decision tree, as I'm doing that medical review of are there other things that could still be contributing that we do need some medical intervention from our pulmonology, GI, and ENT colleagues. Um, Oftentimes, when I am talking to a patient, so what happens, you send the referral to an SLP, right? And the patient disappears, they get worked into the clinic. Um, what will happen is we start with our assessment, and this is where we are going to be talking about their medical history. I'm going to ask a lot of questions. I am fortunate in my role in that I have a lot of time with your patients. And I always joke with my patients that I'm going to get to know them really well. So part of that is just their medical history review, but then asking them some questions as well. Um, I'm going to ask them a lot about their behavioral and environmental history also. These kinds of questions are the things like asking them about the pattern of the cough, the nature of the cough. Is it immediately dry or is it immediately juicy, right? Is it productive versus dry? Those are really discerning questions, and most often the patients that are seeing me, they will tell me, "Nope, it's dry, but if I cough long enough and hard enough, I can make something come up," right? And that to me is an indication of, okay, well, if it's not immediately productive, yeah, you probably don't necessarily need to be doing it, especially if we're in that chronic phase of 8+ weeks post onset. Um, I'm going to be asking if they notice things like a pattern of their cough at all. Are there specific triggers? Some patients know exactly what their triggers are, and I'm sure they're sharing them with you too, Tyler. Of, oh yeah, every time I have to go on a phone call, I know I'm going to start coughing. But by and large, there's quite a few patients that actually do not. And they will come in and they will say, there is no rhyme or reason. I have been living with this for over a year or several years, even. No rhyme or reason, no trigger. There's nothing that tells me I'm about to cough. Um, so then I'll start asking, well, what have you noticed changing in your life because of your cough? And that's where the pattern really starts to come out for those patients. They'll start saying, "Oh, well, I can't cook anymore because I can't tolerate the smell of anything cooking. I can't even be in the kitchen if my spouse or loved one is cooking. I can't walk by a perfume counter. I can't do my favorite hobbies because of exposure to irritants. I can't go to backyard barbecues." And you'll start noticing that there is a pattern after all to their cough. They're just not aware of it. And then from there, usually we do a little bit of acoustic analysis. We are going to take voice measurements just to make sure that there's no presence of dysphonia. Again, usually by the time most of my patients have reached my office door, they've seen one of my laryngology partners, they've been evaluated properly. And so I already know what to expect. But those are still tests that we're going to run prior to initiating any treatment strategies. And then in that first session, we're going to start getting them going with actual strategies of how do we do that behavioral cough suppression training or treatment? What strategies are we going to use? It's straightforward. I'm going to be honest with you. There's nothing when it comes to the actual strategies for managing chronic cough in a speech therapist's office. It's pretty simple, right? It's things like taking a sip of cold water, changing sensory input, swallowing and repositioning the larynx, maybe doing some relaxed throat or quick release strategies and breathing exercises. Um, it's pretty basic. I could print off a handout and give it to you. The difference, but where I think the magic happens, I was thinking about this because I've heard it so many times saying, I don't know what it is you do. It's magical. There's something that happens. And I think I figured out where the magic actually happens. It's the individualization of the strategies to each patient. Each cough is unique. Each patient is unique. And what's going to work for one patient, I guarantee will not work for the next one coming in my door, right? And that's where the speech therapists get to have that little magical moment, if you will.
Totally agree. I think, it's interesting, when you say this magical and mystical thing. And I think that that's how I kind of felt about this
Mm.
when I started in practice. But we know that there's impaired data on this, right? We've got clinical trials.
Mhm.
And so I always like to highlight those in my talks. I think one of the earliest ones that I quote quite a bit, and they have lower ends because this is a subset of patients that have, kind of a less common issue. But back in 2006, right, Bergen et al
Yep.
did an RCT with 87 patients, it was clear that the patients that were doing the speech therapy were doing better than patients that were just having kind of standard, health education. And I think you kind of hit the nail on the head there with in terms of how individualized it is. And I think as someone that sees chronic cough, I agree, no cough is the same. And I
Mhm.
think it becomes difficult, as an advanced practice provider, nurse practitioner, I do get extra time with patients, but sometimes what you just described is in even more of a deep dive. And I think this interdisciplinary, collaboration between, ENT, pulmonology, and speech therapy is something that people really need to understand. And
Mhm.
if you can find those speech therapists that are doing this, it's really important because I can attest that you guys do great work and I've seen my patients, really do well with this. And so I guess what I wanted to kind of go, and you kind of started talking about this, is kind of walking us through a typical patient case you might see. So maybe if you have maybe a recent case that you could maybe walk us through, that you kind of talked what you're assessing for, and maybe how you proceed with treatment plans. I know you kind of talked about what you do in your first visit, but what does that kind of timeline look with a typical patient that you're doing this with?
hmm Yeah, that's a great question. So typically, for a standard run of the mill chronic cough patient where there is nothing else going on, it is purely just they have a dry, non productive cough that interrupts them enough that they're seeking treatment and being willing to even go to the speech therapist, right? Not understanding how that's going to work. Um, the average treatment process is usually 2 to 3 treatment sessions. And that we usually so I'll do my evaluation, I'll get them started with some techniques, I'll explain how I want them to implement those techniques. If I decide they need to do some kind of a cough journal, a very simple I try to keep it really simple for patients because at this point in the game, one thing that can kind of happen for this patient population is they almost feel like they're a victim to their cough, right? It has been so disruptive to their life and their quality of living, and they just feel like they have no control. So recently, I had a gentleman, he's about 59 years old, come in and see me, and he had had a chronic cough that started up after he'd always kind of had a history of, when he got sick, his cough lingered, right? But it would eventually get over. This gentleman had had an upper respiratory infection about 8 months prior to coming into my clinic, and he had tested negative for COVID at the time. Seemed like a standard upper respiratory infection. It took him down a few days, but nothing too serious, no hospitalization required or anything like that. And so he worked throughout his infection. He continued working. He was working in tech at the time, had to do a lot of virtual meetings, a lot of phone call based meetings, and would just kind of struggle his way through the meeting to be able to continue working. And by the time he saw me, he had seen pulmonology, had been fully worked up. He had seen ENT, he had seen GI, and trialed inhalers, trialed proton pump inhibitors. He had trialed Tessalon pearls. He had found the most relief by using cough syrup with codeine, which he couldn't necessarily use all the time because of risk factors associated with that. But ultimately, his cough just seemed to be worsening. What he started noticing was that anytime he would go to even start a meeting, before the meeting had started, his cough would start, right? Just entering into the environment, it's almost like an operant conditioning or association that starts to develop, I found for these patients, where just going into the environment that they know and have had experience where maybe there has been almost like a panic response that's been established that's triggering that strong cough, they start having symptoms, right? Just even entering back into that environment. So for him, our big focus, and I kind of jumped in and started talking about the evaluation process within treatment. So when it comes to the treatment of these cases, the three main things that we're going to focus on are improving the laryngeal hypersensitivity and trying to improve that laryngeal environment. That can look like a lot of different things. If there's a history of reflux, postnasal drip, and allergies, we want to make sure we have concurrent treatment of all of those things happening at the same time. If the patient is having issues with dehydration, right, we want to make sure that the vocal hygiene of maintaining a well lubricated larynx is there at place. And then we're going to move into those cough suppression strategies. But before that, we also have to train the awareness. So for this gentleman, what we ended up doing was we worked on improving his laryngeal environment. I actually had him start using a headset with video calls because he found he didn't have any muscle tension, dysphonia, no voice changes or anything like that. But he found himself when he was talking virtually, straining. He felt like he was almost having to shout, and then the cough would start, and he felt like he'd start this tug of war with his throat as he's actually trying to speak and make it through the meeting. So we worked on implementing some strategies just to help to reduce and make it easier so he wasn't having to strain as much. Then we did some work with hydration, and we actually started doing some desensitization, environmental training in anticipation of the call. So it became imperative for him that we would use some of our relaxed throat breathing exercises. I'm partial to a gentle, quick sniff in 1 or 2 times in through the nose, focusing the turbulence of airflow directly at the front of the nose. And then focusing the exhale. I find that when you focus the exhale, you get that vagal nerve stimulation that just allows the system to calm down, right? And it helps to de-stress and allows the patient to give them a little bit more time to prepare and respond to the cough, if you will. So prior to going into his calls or his meetings, I would have him implement his relaxed throat breathing strategies just preventatively. And then I had worked with him on structuring of when you find that awareness, he also did a very simple cough journal to help him understand when he was making progress. He was one that came to me and he said, "Listen, I'm skeptical. You're a speech therapist. I don't understand what you're going to do, but I'm desperate and I just need to survive this cough." So we used the just a simple, tick system to help him understand how often his cough was happening and to develop some awareness around when the cough was happening without it snowballing into that victim kind of mindset of, "I have no control over my cough." So then I would include with that, "Okay, what worked, what didn't? Let's come back to the drawing board when we meet again." So in his first session, when he came back to see me, and then I also had him sipping water during meetings, as well as implementing his relaxed throat breathing to interrupt the onset of his cough as well and delay that. He came back for his first treatment session and he reported to me that he reduced his cough frequency to about 30 to 40% of the time using his strategies. And he had been faithful in using that cough journal. He was a data guy, so he really liked to have that data to compare to. And then he came back for a second treatment session a couple of weeks later, and he told me, he said, "You know what? I feel like I have control 70, 80% of the time. The remaining 20 to 30%, if I let things slip, it creeps back in. But I just jump right back on those strategies and it doesn't bother me anymore." And he said, "I'm good. I don't need to be seen anymore." And I hope he's still doing well. And I haven't heard
Yeah.
from him. So he was a straightforward cough, right? Chronic cough, just that dry, non-productive, often triggered from talking or a situational environmental thing that we need to take into consideration. And his treatment approach was really straightforward too.
Yeah, and you bring up cough hypersensitivity, and I neglected to bring that term up. That's actually what we're talking about with refractory chronic cough, right? And it's interesting because I think, when we think about chronic cough, it's technically a symptom, especially when we're talking about diagnosis codes. But when we're seeing these patients with refractory chronic cough and this cough hypersensitivity, I mean, there is objective evidence that there's more neurological things going on in the airway epithelium of these patients, right? It might be or it is, in my opinion, kind of its own entity of disease. And I think that we're kind of progressively looking at refractory chronic cough or cough hypersensitivity syndrome as that. Um, and I think the other thing you kind of talked about was with, his 30 to 40% reduction. I think, they've done qualitative studies, I think, that shows, I think patients, if they get a 50% reduction, that's very significant to them, right? In ways
Absolutely.
that we kind of, right, in ways that we track that too. I know we both use the Lester Cough Questionnaire, right? A
Right.
validated tool. We actually just got it implemented so that our patients can fill this in on my chart before they come in now. This is a really easy, 5-minute questionnaire that we can give to patients when they're checking in for their appointment and kind of trend that over time. And I'm a data guy as well. And where we work, we see a lot of data driven people that love looking at these scores. And it's beautiful to see, with the Lester Cough Questionnaire, it's out of 21, to watch that number go from 10 to 14 to
Yeah,
18
right.
to 20 over time, and really kind of having some objective validated tools to kind of support that, right? Now, you talked about a lot of different techniques that you do, and I was hoping, I think this is kind of where the magic really is, because I think people just don't understand what these techniques are and
Right.
how they're working. You alluded to a few of them, but I guess I just wanted to summarize a little bit about the various techniques you use. Obviously, no two patients are alike, so I'm assuming you're probably using different techniques for different patients.
Yeah.
If you maybe just want to go through a couple of these techniques you do, the rationale and what this accomplishes for these patients.
Yeah. So, laryngeal reposturing is a big part of retraining, as well as I would say one of the most important things is to work on desensitizing that laryngeal hypersensitivity component. And so That's kind of a precursor, I would say, to actually using the individual techniques. The individual techniques are straightforward. Suck on some ice chips, drink some cold water, change the sensory input to the system, do a hard swallow, um, doing that sniff inhalation or and with the focus per slip exhalation, pausing. But before that, patients have to know that they're going to cough, right? So awareness, part of that awareness piece, I will ask patients, what symptom, what's the little flag that goes up in your throat that says, "Oh, I need to cough?" By and large, patients will describe to me the sense of itch, tickle, mucus, phlegm, or some combination thereof. Those are the most common, maybe even dry. Those are the common words that I hear patients use to describe that little precipitating symptom that says, "Oh, I'm about to cough." So what I will do once we establish whatever it is for the patient, it's different for everyone, and some might say there is no signal. So those cases are usually a little harder because I'm trying to get them to develop that mind body connection a little bit more. Um, but for those who can identify what that symptom is, that's when I'm going to say, okay, when you feel that tickle sensation, I want you to take a sip of cold water and swallow. Basically, what we're trying to do is delay the onset of the cough. I tell my patients, listen, I'm not going to eliminate your cough straight out the gate. If they end up eliminating their cough in that first session, fabulous. That's great. But managing realistic expectations. My first goal is going to be to delay the onset of their cough. So when we can say, oh, I feel that itch, and then I'm going to cough as a response, then we can intercede and use one of those strategies that I just mentioned to space it out, and it gives them time to decide, do I need to cough? Right? I'll tell patients it's going to put you in the driver's seat. You're going to say, and sometimes I'll describe it like it's a mosquito bite. The more you scratch the itch, the more the itch happens. And that's how, and when I say that, patients usually like, oh, that does make sense actually now, right? There's more irritation happening in the larynx. Um, I'll describe their hypersensitivity because a lot of patients will say, I have so much phlegm. Tyler, I've got so much phlegm. There's just all this gunk sitting in my larynx. I can feel it. ENT scope, laryngeal exam. If anything, they might be a little dry, right? They're
Hmm.
looking
Hear it all
pretty
the time.
all the time. They're like, no, no, no. I know it. I know that nobody can see it, but it's there. And that's where the conversation about the sensitivity threshold comes into play. And I'll explain it to them and say, listen, your larynx should be sensitive. We want sensitivity because it's a big airway protective mechanism for when we swallow, right? One of the other big areas I treat is dysphagia. I want my patients to have a healthy sensitivity in their larynx. But the problem for these patients is that that laryngeal hypersensitivity, the threshold is so low. And I'll describe it to them as what feels like for me or you, somebody who's not dealing with that laryngeal hypersensitivity, for them, it could be something just like air flowing if they take a deep breath and boom, they're going to trigger that big, huge cough. And then they're going to be coughing and hacking away. Maybe they have some kind of incontinence with it, right? So for them, even just air passing through the larynx will trigger an apocalyptic like response. And they'll think, oh my gosh, I'm choking on everything. I have all this phlegm. No, it's just that that sensitivity threshold needs to be brought up. And doing the strategies I have found when we can identify, hey, here's that tickle sensation. Now let's use a strategy to space it out. We also start getting some of that desensitization starting to happen because they're able to then use strategies like the sniff. So you do two quick sniffs in, exhale, slow pursed lips, calming that, allowing for that vagal nerve stimulation, calming that system down and allowing them time to decide, do I actually need to cough? And that's where they're going to start retraining it and realizing, oh, I really don't need to cough. I'm fine. And I have a more of a structured approach that I'll use with patients where I say, take a sip of water, swallow hard, do that breathing technique 3 to 5 times. If you still feel the urge to clear your throat or cough, I'll teach them how to do a gentle throat clear or a silent cough just to help if there is anything that needs to be, removed from the airway. And then we go right back to step number one. And pretty quickly, if they're pretty consistent with it, they're going to see a reduction in first delaying the onset of their cough, then reduction in frequency with the goal of hopefully eliminating that chronic cough.
Yeah, it's just really interesting because we definitely know that there's this kind of neurological basis for kind of what's going on. And you guys are basically helping to, first of all, really kind of deep dive into what is the trigger and really working with patients and kind of helping them rewire to kind of
Mhm,
live with this, right? And while it's not always going to be the be all end all, I can say just in my practice, I've always seen such excellent success in doing this. But I think the point is there needs to be a good collaborative effort between us both,
mm,
and also an understanding of just what speech language pathologists offer to this. You've really, I mean, we could talk about this for hours, and I think you've given a lot of really good information to our audience. And I think one thing I wanted to ask you was, a couple of things that I hear often from people is, maybe we don't have speech therapists, or maybe they're not connected with speech therapists. And so I want to hear from you what kind of insight or advice you have for NPs and PAs that are working in pulmonary medicine, specifically maybe ones that don't have easy access or are not aware of speech therapists. What kind of insight or advice do you have for them when they're treating patients with chronic cough and they get to that refractory point?
mhm. Yeah, so there's not really a good certain, certificate-based programs you can, sign up as part of the registry so that you just go on the registry and find the people. There's really not one for chronic cough. I think knowing how it fits into a SLP scope of practice. Again, chronic cough for us, it follows along that irritable larynx syndrome continuum. And so the people who are going to be able to treat it are the people who are doing voice therapy, right? That's where chronic cough is going to fall under. So if you're looking around at clinics and you see a clinic that offers voice therapy, there's probably an SLP there that can help you with that patient and figure out. Like I said, the strategies themselves are simple. They're really basic. They're very simple. It's how we apply it and how we work with each patient on the individual level that changes, and the SLPs doing voice therapy, that is so much of what we do already. We talked about if it's just straight chronic cough patients, but sometimes I'll have patients where they also have a component of muscle tension dysphonia or laryngospasm, and so I'm having to treat multiple things at once, and that's where you'll also see treatment sessions get extended, is if there's a component of muscle tension. So when looking, look for those SLPs in your area. Their SLP therapy is allowed as of right now to be offered virtually. There are some rules based on, location as far as, to be in the same state and all of that. As for now, it's still offered virtually. So that could be an option also if there's not a provider who offers, for voice therapy in your city, especially in the more rural communities. Start looking outside of that and see, is a patient willing to travel maybe for an hour or so just for the initial evaluation, and then there be a virtual format. I find chronic cough doing virtual visits works very well for this population. This population is very isolated, I would say. There's been a lot of ostracization, I think, in a post-COVID world, right? A lot of embarrassment, a lot of public shame that can happen. Some of the stories my patients come in with are just truly kind of heartbreaking. And it's, they're trying to explain to anybody and everybody, "Oh, I'm not sick, I'm not contagious, I just have this chronic," and they try to explain things and it's kind of so they would almost prefer to be seen from home. And even coming into a clinic where you're treating chronic cough, they will still be asked, "Do you have a cough?" by our front desk in trying to protect other patients and providers. The answer is yes, that's why I'm here. And, prior to how things are now, but I had patients that were told, "Oh, you can't be seen if you have a cough." And that caused some confusion. So that became an opportunity for education with me and our support staff as well. But that is also an option. So I would say if you're a pulmonology specialist and you're looking for an SLP, um, look online, figure out who does voice therapy in the community. That's where you're going to find the SLP that can help you. If there's nobody nearby, look at local schools. If they offer a speech program for graduate school, they can probably do some clinic work there in a college setting as well. Usually there's college clinics as well. And then reach out to the SLP. If you see an SLP that maybe is interested, start having conversations like you and I did and our wonderful ENT partners and pulmonology partners. I think that multidisciplinary approach is so crucial, especially for this population where they are being so heavily impacted by their cough and the way it's impacting their quality of life. That finding those practitioners who are interested in learning, I guarantee you'll find an SLP who's wanting to. Maybe they haven't ventured into that area. It does tend to be an area that people are feel less confident in going into sometimes. But maybe just having that partnership will encourage them that, oh yeah, this is something I can do because it's pretty straightforward.
Absolutely. Yeah. I said make BFFs with your speech language pathology colleagues. And I think one other plug for for speech therapy is sometimes when I'm seeing a patient and I'm pretty suspicious of an upper airway cause, I'll refer them to ENT, but oftentimes I might actually refer to both, or we'll start with speech therapy. And I think a lot of times you are discovering other things, right,
Mhm,
with these patients. And whether it be even a swallowing issue. I mean, how many
mhm,
times have I gotten a report back from speech therapy saying, I did this thorough evaluation and I'm concerned about XYZ now. And I think that's another plug for multidisciplinary approach, because we're now kind of thinking we were just dealing with a chronic refractory chronic cough, which is probably a component of this, but there's other things that we have now identified in the assessment. And I
mhm.
wouldn't have been able to do that without you or ENT. So I think it's just a really important relationship that we have. And then more importantly, that we kind of really understand how everybody works in this. And I think you've really highlighted the great work that you guys do in this field. So I think just to kind of wrap things up, we've talked about quite a bit. We could be here for hours. We could bring Rachel back. It's too bad we don't have a Q&A, because we probably could have a pretty good session. But I think it's just important to really know refractory chronic cough. It's this really debilitating problem for our patients, and I think it's really becoming its own disease entity, and there's not a one size fits all for this, right? I think, yeah, there's some exciting things in the therapeutic pipeline that we're going to see in the next, few years. But speech language therapists are going to be what you have right now, and I think that they are. I think what's interesting is it's kind of this mix between behavioral therapy and using these behavioral tools to really reduce that with this hypersensitivity is doing to these patients. And I think more importantly, this collaboration between especially nurse practitioners and PAs that are seeing chronic cough patients on a regular basis, to really explore and develop that relationship with their speech language pathology colleagues. And using those guidelines and algorithms and validated assessment tools that we have, to really monitor this and do our due diligence for our patients.
Mhm. Yeah.
So thank you so much for coming on today, Rachel. Do you have any other pearls that you want to share with our audience?
Oh gosh, just, that's a great question. I think look in your communities. Find that SLP. I guarantee there's an SLP somewhere that's willing to work with you and your patient and wants to help. So I think just keep an open eye out. Know that it's under that voice umbrella. So, like I said, if you see somebody who's doing voice therapy, they can probably help you with your cough.
Perfect. I'd like to thank everybody for tuning in today. Of course, please like, follow, subscribe, and share our podcast to your colleagues. And if you want to get your CME, make sure that you follow the link that's going to be in today's show notes. Or you can visit our website under the podcast. There's a link there where you can claim the CME credit. Thank you so much, everybody.